I wanted to welcome everyone to our first NephCure U of 2022. My name is Kristen Hood, and I am the Executive Director for Research Engagement here at NephCure. And I'm your moderator today for this educational webinar on transplantation. We have an amazing physician today from Mass General Hospital to give you updates on kidney transplantation. But first, I'd like to let everyone know that this webinar is being recorded. You should have gotten a little pop-up telling you that. And it will be uploaded to our website as well as our YouTube channel by the end of next week. So if you are interested in sharing this or watching it again, it will be available to you. Throughout the webinar, please feel free to put questions in the Q&A section of the Zoom toolbar down at the bottom of your screen. Most people should be pretty familiar with that function by now. We'll answer as many questions as we possibly can to the very end. We are ending this webinar right at the top of the hour at 1 o'clock Eastern, out of respect for Dr. Riella and the patients that he sees on a daily basis. But now it's my pleasure to introduce to you Dr. Leonardo Riella. He is an MD, PhD, and holds the endowed chair in transplantation and associate professorship of medicine at Mass General Hospital and Harvard Medical School. He's also the director of kidney transplantation and a senior investigator at the Center of Transplantation Sciences. His research is centered around the goal of prolonging the life of transplanted organs by better detecting transplant rejection and applying novel treatments to re-educate the immune cells to tolerate the transplanted organ. He has a special expertise in challenging cases such as antibody-mediated rejection and the recurrence of glomerular disease after transplant. He has an active research laboratory and truly understands the mechanism of immune regulation in transplantation. And that is why he is here today on this topic. And so please welcome Dr. Riella. He's a longtime friend of NephCure, and thanks for being here.
Thank you so much, Kristen. My pleasure to be here and share the next hour with all of you. I think there had been so many excitements in the world of kidney transplantation in the past year, and I decided to divide the talk into kind of three parts. Of course, we have to talk about COVID. And maybe, in a good sense, we'll talk about COVID and some of the positive prospects that we're seeing in the upcoming months. But we'll also talk about kidney transplantation and some new insights that we have about the immune system. And we touch somewhat at the end about the Fsgs Recurrence. So if we look at the trends in the past 6 months, what we're seeing is that the cases finally are going down again. And we were expecting this to happen, last year, and indeed the numbers had been low, but they had this kind of large spike that started at the end of November, beginning of December, and this, frustrated a lot of people because we thought, COVID was gone. In addition to the statistics that the government and other organizations report, I find this one in particular extremely interesting. So this is a COVID-19 tracking of the virus in wastewater. And it's one of the best, predictors of what's happening with the pandemic in your location. Just because, a lot of people are now using home tests to get tested for COVID, and sometimes we don't get that reported anywhere. But if you look at those wastewater and the presence of virus in wastewater, and this is in Massachusetts, you can clearly see that we're on a much better trend now with this peak kind of happening, at probably end of January, and now we're back in March, significantly down. So number-wise, I think, in Massachusetts, we're doing well. Of course, there's some differences across the states, but we are seeing this wave of COVID going down. And why did we have, again, this kind of peak? And part of it has to do with all these variants that have occurring with the SARS-CoV-2, the coronavirus. So they undergo some spontaneous mutations. And then we had, for example, the alpha strain, and then we had, the beta, then the delta, then the gamma. And lately, the one that caused this latest peak was what we call the Omicron. And why is it important to know about these variants? Because, when we look at the main protein that kind of is outside the virus of the coronavirus, when you have these variants, what comes with them are significant mutations. So changes in the protein that forms these receptors. And here I have an example of the Delta, the Gamma here, and the Omicron here. And what we can see with the color is all the new mutations that had formed. And compared to the other variants, the Omicron had the greatest number of mutations in that surface of the protein. And there are a few things that we learn about the Omicron variant that's worth describing. Number one, the symptoms duration seems to be much shorter than the Delta. Two, that the cases are much milder than we have seen with COVID before. So low-grade fevers, much less lung involvement. And the majority of patients that ended up getting the Omicron were actually vaccinated. So these were kind of breakthrough infections. And in part, one of the reasons why vaccines do not work as well for the Omicron, it has to do with all these mutations that the virus had spontaneously developed. So they evade the immune system much easier than some of the other variants. But on the counter side is that the potential for these viruses to cause very severe disease in vaccinated patients is extremely low. And we've seen with just vaccination how impactful it had been. And this is by itself an amazing, scientific development that had occurred in terms of how quickly these vaccines were able to get developed. But this is data from the CDC comparing unvaccinated patients in green with vaccinated patients and showing how significantly it can lower the rates of the disease severity, lower the rates of hospitalization, and lower the rates of mortality. So the impact of vaccination during this whole pandemic had been incredible, and we would be in a much worse position if we didn't have that. Of course, for our kidney transplant patients, there's always this question of how good is the vaccine in somebody who takes anti-rejection medications that weakens the immune system? And this was a concern from the start of the pandemic based on some of the prior work that we knew about vaccinations in general in transplanted patients. But I'll share with you some data from our group looking at vaccination. And here we're looking at 3 doses of mRNA vaccination and looking at 2 specific questions that we have. One was about safety. There's a lot of issues and concerns from patients about, am I going to get the vaccine and suddenly trigger a rejection of my kidney transplant? And this was, of course, something that we were tracking very carefully. But on this study, we were able to go, another level up in terms of the monitoring that we're going to do to try to detect rejection. And 2, what is the antiviral response that's generated in transplanted patients that get vaccinated, particularly with the 3 doses, because the majority of our patients now already have gotten at least the 3 doses. So the number one question had been specifically about how much of antibody do we generate after the 3rd dose. And then what I have here is the antibody response against all the different variants of the SARS-CoV-2. And then if you look here, after the 3rd dose, you significantly improve the antibody response rate against the virus. And you see that, across all the viruses, the response is in general good. It's better for the initial variant when that has an antibody response rate up to 67%. But even for the Delta, it goes from 2 to 25%. So there's definitely an improvement, even with the 3rd dose, in terms of responding to the vaccine against the Delta variant, which was the latest spike. What about the Omicron variant? So the Omicron variant, because of all those mutations, unfortunately, people generate an antibody response, but it's much significantly lower in transplanted patients than in the general population. For example, here, prior to the 3rd dose, no patient had antibody that could neutralize the Omicron variant, while after vaccination, only 12% had an antibody response. So which tells us that, unfortunately, the vaccine that we're currently using is not as effective in producing antibodies to neutralize Omicron. However, it is still possible that the vaccine protects us by stimulating our cellular immune response, which is the other branch of the immune system, and still prevents us from getting worse infection or infections that may lead to greater complications, hospitalizations, and mortality. So I think, overall, it's one of those things that the more vaccines that we get, the better antibody response we do. And there might be variations of new vaccines coming out that will be more specific, for example, for the Omicron variant. And we expect this to be coming in the next few months. What about the safety of these vaccines? And we tracked, of course, the serum creatinine, we tracked proteinuria as markers, and we didn't see much difference across 1, 2, and 3 doses. But we also did other tests, such as donor cell-free DNA. We also look in the urine for rejection markers, and we also look in the peripheral blood for a gene signature for rejection. And what we can say for sure is that, in our study, by looking very carefully at over 60 patients, we did not detect any signal about risk of rejection with vaccination. So the benefits of vaccination outweighed any potential risks that we could see. So the third dose of SARS-CoV-2 mRNA vaccine in kidney transplant recipients is associated with an increasing antibody response against the wild type and Delta variant, but the neutralization to Omicron remains diminished. So more coming, I think, on new vaccines that may protect our patients. The third part is that, the safety is amazing. So really, there's very little evidence that there will be significant risks of our patients to get vaccinated a second or third dose with the data that we currently have. The CDC recently put out a new protocol in terms of when you get your booster dose, and they shortened to 3 months after the third dose. And these in particular are for transplanted patients that are considered either moderately or severely immune compromised. So this is an example of the Pfizer and Moderna. So after you get your 3 shots, then you should get a booster dose 3 months afterwards. And Janssen here on the bottom, that it's a little bit different because you have a first dose, an additional dose, and then a booster dose 2 months later. But this was a new change that came out based on work that came from our lab and other researchers showing that it's really important to have that extra stimulation of your immune system to prepare it to fight the COVID infection. The second part that I think it's very important about as we talk about COVID is about masking, because of course, as the pandemic kind of starts waving, there's big questions about, should we still wear a mask or not, and what type of mask you should wear. And it depends a lot on what's happening in your community. I think, in the hospital perspective, we're going to continue to wear masks. I think it creates another layer of protection, in particular because some patients and some even providers may be asymptomatic and may have the virus. And if somebody has not of a great immune system or do not mount an effective response against infections, it could create a higher risk. So there will be major changes, I think, from what we've known prior to COVID in terms of where do we define the wearing of masks. But then, of course, as the numbers come down in your community, I think there will be patients that would feel that they want to use the mask just to feel that extra layer of protection, while others may decide that they don't want to go down that route. And I think we got to accept that as long as the rate of infection in your community is very low. I personally, in the hospital, continue to wear a mask. One of the important things about the mask is just to make sure that it's tight, right? So if there are big pockets where air is coming in without going through the mask, these are not very good masks. And that's why the NK95 and some of the other masks that are a little bit more sealed, they tend to give an extra protection to patients. So in general, just make sure that your mask is tighter and fits well. And depending on your face, you may have to try different types of masks. And when you're in public, if you're going to go to a place where you feel that there will be risk of exposure based on your community infection rate, I think using a mask is very reasonable. So from the COVID, we'll try to kind of change some gears and go into kidney transplant and the immune system. For those that unfortunately are not yet into the transplant world, when we think about kidney disease, there's a lot of reserve, there's a lot of protection that kind of happens from the kidney, and it takes a while for the kidneys to completely fail. But we want to kind of usually see patients for transplantation when their GFR gets below 25 to start preparing for things. And preparing because it takes time to go through the whole transplant process, and we want to have the opportunity to be able to try to transplant patients before they have to go through dialysis. And unfortunately, we don't have enough kidneys, and there are two options for you to get a kidney transplant. Either you have a living donor, and that's the best case scenario because we can plan surgery whenever you're getting close to needing dialysis, do the transplant. But if you don't have a living donor, then you have to go through a waiting list to get a deceased donor. Unfortunately, that varies a lot depending on the region that you are in the country, but can go from 4 to 6 years of waiting time. And of course, the living donor, as I mentioned, is the best one because of the ability to time it, and also to get a kidney from a healthy individual and maybe a family member that has a very good match to the patient who has the kidney disease. And just to give you an idea about the numbers, we have over 100,000 patients on the waiting list right now, and there's only about 12,000 kidneys that are offered on the deceased donor per year. So there's a major gap between the patients who need and actually the number of kidneys available. And that brings to some of the very recent advancements in terms of xenotransplantation. And I thought it was interesting to at least share 3 slides about it because there could be a lot of confusion about that. And so, for more than 40 years, there has been many research groups working on transplanting a pig kidney into humans. And the reason to use pigs is that they have a very similar body compared to humans, and also they reproduce much quicker compared to monkeys and other individuals. However, when we think about the pigs, there were major barriers that were found as all this research were going on, transplanting pig kidneys into monkeys. And the first part of the challenges was that there are a few sugars that are expressed on pigs in which humans have antibodies against. So if you would transplant this pig kidney into a human, they would reject the kidney immediately. So it's almost, if you think about the ABO incompatible, everyone has a different ABO group. You cannot give a blood transfusion to somebody that is a different blood group than yours if you have antibody preformed. This is very similar. So by evolution, we ended up developing these antibodies against specific sugars that are present on the pig. So it was not until there was a major advancements in removing genes from the pigs using a CRISPR technology that investigators were able to actually mutate some of the pigs by removing 3 of the main sugars that are present in pigs that we know that humans have preformed antibodies. So this was a major barrier that was surpassed in the past 10 years. The second thing was that whenever these pig kidneys were transplanted into monkeys, they generated a lot of inflammation. So the mutations were added to pigs in order to try to minimize some of that inflammation by inhibiting the complement cascade. And third, the investigators, by doing many experiments, starting to better understand what type of immune suppression, what type of anti-rejection medications will be needed whenever you do a transplant from a pig into a human. And this led to many very positive results in transplanting pig kidneys into monkeys. And this is just an idea of how long these kidneys have been surviving. And now if you go to 2019, we have now kidneys surviving for more than 1 year in monkeys and functionally completely like a normal kidney. So this was not like a quick process. This has been research going on for more than I'll say at least 30 years that led to experiments in monkeys showing this long-term kidney survival. And finally, we have now a first demonstration in humans that connecting a pig kidney, a mutated pig kidney into a human would not lead to the immediate rejection of that kidney. And this is just the design of the study that was just published on the American Journal of Transplantation. And they had, they were very fortunate having a family who agreed to allow their loved one that was deceased, it was a brain dead donor, to undergo this procedure, which was transplanting a pig kidney into this brain dead donor that unfortunately was not a good candidate to donate other organs to patients, and then to watching this kidney for about 3 days after transplantation. And this, why it has been a major step forward, because it really showed that, by transplanting that kidney, there was no immediate rejection of the kidney, demonstrating that all the mutations that have been done in those pigs are really translating into the feasibility of potentially moving this to the clinic. Of course, there are many steps yet that are needed to be overcome. We have to know what happens in the mid and long term if we transplant into a patient that, for example, is on dialysis, and also how can we better control the immune system, and if the medications that we're using monkeys are going to be enough to control the same process in patients. But I think this was a major development in the transplant field, because it really permitted and demonstrated that this is possible, and finally is arriving to a point that small pilot studies in humans may occur. It is not something that is going to be offered to all patients in the next few years. It's going to take much longer to scale this up, but I think it is quite exciting, in particular for patients that unfortunately don't have a living donor and may have to stay on dialysis for long. And this is how the kidney look after 1 day of surgery and after 3 days of surgery, showing that they look good. There was no evidence of rejection. And we'll be hearing more about some other groups in the country very soon that have also performed a very similar experiment. So I think there are going to be a huge learning curve in this next year to come. The second part about kidney transplant that I'll touch a little bit on has to do with how can we better monitor our kidney transplant recipients. So we use creatinine, we use protein in the urine as potential markers, but we know that both of them can be late markers of kidney damage. So we've been working very heavily in the lab for the past, close to 10 years in developing other types of monitoring tools that could be done at home, that could be done without any fancy equipment, that could be done cheaply, and that can highly detect, any problem or any danger ongoing. Almost thinking about something similar as a pregnancy test, where it kind of gives you, a quick test and it doesn't require much equipment on the background. And what we did is we use, the same CRISPR-Cas technology that I told you that had been used for pigs. We adapted that technology to actually detect certain markers in the urine, in particular markers that may tell about inflammation in the kidney, such as CXCL9, or certain infections that may affect the kidney after transplantation. And the results is given as almost like a little cross, similar to what we know about the pregnancy test and many of the COVID tests that you guys have been doing. And what we show on this study that was published now a year and a half ago is that it is extremely sensitive to detect rejection in transplanted patients. And not only that, it can detect rejection, but it can detect also subclinical inflammation from other causes. So this, I think it's gonna, in the next few years, really kind of change the way we monitor our patients post-transplant, because we would allow a much more frequent testing at home of the urine. And, in case something, is positive, to trigger next steps, including getting a blood test, including getting a further workup. So we're really kind of excited to, start moving this to the clinic very soon. And the reasons why we think that this test is so exciting is that we can really do an earlier detection of the injury before creatinine goes up. It is very low cost, and it would allow not only to monitor for rejection, but also infections in the urine. And I think this is a better way and more comprehensive way to kind of track some of these patients post-transplantation. I would have to talk about a little bit about microbiota and nutrition, just because this is another part that in the whole immunology field in science, we have learned so much. We have learned, for example, how important our microbiota is, and also how important the nutrition that we take is in terms of modulating that microbiota, and how there's a whole cross conversation between what happens with your food and how it affects the microbiota, your immune system, and even the kidneys. And I'll tell you, two brief stories about it. So one was the Genie study that we have shared with NephCure a couple of years ago, where we took some kids that had steroid resistant nephrotic syndrome that are unresponsive to any therapy, and we placed them on a summer camp where the major intervention was actually a dietary intervention. So the diet for 4 weeks was a gluten-free, dairy-free, low-salt, organic diet with low protein. And after this, 4-week studies, we were able to actually monitor these patients very carefully, and we monitor a number of different factors. These are all the 16 kids that were part of the study, and that I had the pleasure to kind of learn and from them, and also join the research study. And there were two things that were very surprising. I think number one is that we had 2 patients that went into complete remission just with the dietary intervention during the study. This is patient 1 and patient 6. And remember that the other patients had tried all sorts of treatments, and the diet had been on these 2 patients really, really impactful in terms of getting their proteinuria down. And also, these patients went back home, they continued the diet, but then when they got re-exposed to gluten, they ended up having a relapse. And it kind of told us that, there is a subset of patients that have nephrotic syndrome that may have some sensitivity to the diet. And we found out that potentially this could be mediated by a molecule called zonulin. And it is, something that we're learning more and more about it, but it seems that some gluten sensitive individuals may produce more of this zonulin that can then cause the nephrotic syndrome in the kidney. And the zonulin can actually open up the tight junctions that keep cells together. And this is a potential mechanism that the 2 patients that responded had the highest levels. Of course, this is a small study, and we need to, of course, validate the importance and the relevance of zonulin too, but it definitely showed a potential mechanism there. But the second very surprising thing is that independent of the patients who had remission from the nephrotic syndrome, what we did see was the major impact that this diet had on the immune system. And this was very surprising, because whenever we study humans, everyone is so different, and we can clearly see how different they started here on day 0. But once we place all these patients on the same diet and we look at their immune system on 4 weeks later, their immune system, and in particular this pro-inflammatory immune cell called Th17 cells, which is one of the most pro-inflammatory autoimmune cells present in our body, had significantly reduced by a rate of 82%, which, for us, it was so impressive that only a dietary change without changing any of their medications we can have such a significant impact. And the balance between those regulatory cells, which are cells that suppress our own immune system, and Th17 cells were significantly increased in patients that underwent that 4-week dietary intervention. So what we learned with that is that, not only this diet, or a more strict diet, healthier diet, could impact nephrotic syndrome, but it could also significantly impact the immune system. And we know that many of these diseases have an immune system dysregulation as a background. So this is really, I think, an exciting part about us not only thinking about medical treatments of our patients, but also thinking about the nutrition, and thinking as really part of any treatment of patients who have kidney disease. And so what we concluded with this is that the diet can have a very strong anti-inflammatory effect independent of any medications. Second, that gluten sensitivity may contribute to nephrotic syndrome in a subset of patients. We also learned that higher zonulin levels may identify some of these patients that are more responders. And the fourth is that we need to do a better validation of this going forward, potentially using zonulin as a cutoff. But until we get there, for patients that have persistent nephrotic syndrome and not responding, we are definitely recommending a trial with the help of a nutritionist of doing some gluten-free and healthier diet for a period of at least 2 to 4 weeks, and reassessing after that if there's any response. And with that notion, we'll touch a little bit on the Fsgs recurrence. So this is, one of the patients that got me into the field. So was a 30-year-old that had been diagnosed with FSGS at age 23. She presented with, a lot of proteinuria in the urine, a lot of swelling, and then she underwent a kidney transplant that unfortunately kind of failed after 3 years due to the Fsgs recurrence. And now she came to my clinic and she's asking multiple questions about getting a second transplant. And I think this is something, a major challenge in the field in terms of what do we do with these patients and what other tests that can we do to help them decide if it's worth going forward or not. What we know about FSGS, and that I try to make it kind of very simple, is that there's injury to one of the layers that forms the barrier filtration of the kidney, which we call the podocytes. They have different terminologies depending on how bad the damage is and how long it lasts, this damage to the podocytes. There's minimal change to the FSGS, there's collapsing, and all these are, have in common that they are affecting this layer of cells. So this is, I think, an important concept about it. The second important concept is that, we tend to say that FSGS is a disease, but in reality, there are multiple things that can cause the podocytes to get injured and cause it to get scarred. And I think this is where I think the field is just learning so much in the past 5 years. And this is how I simplistically try to bucket the different causes of FSGS. So you have causes that may relate to specific medications that patients have been exposed. You have causes of FSGS that are genetic in nature. So patients that have a genetic predisposition that either have a second hit or they present with nephrotic syndrome from a young age. And we have the specific group of patients that we call, or I call at least, that it's had the systemic FSGS. So why is it systemic? Because we believe that there's a circulating factor released most likely by the immune system that causes the podocyte to get damaged. So whenever you put a new kidney in, new transplanted kidney in somebody who had this type of FSGS, they can have the immediate recurrence of that FSGS after transplantation. And there are many evidence in different studies suggesting that this is the case. But what is elusive right now is, what is this circulating factor? And could there be more than one circulating factor explaining that? And this is, how we ended up launching the TANGO study, TANGO Consortium now, a couple of years ago, to mostly focus on studying glomerular disease recurrence, in particular FSGS, with the idea of better understanding how centers are actually treating this. How can we put our heads together, get samples from these patients to help study this disease, just because it's very rare, and each individual center may have a handful of cases every year? And how can we think of this kind of going forward? How can we apply trials to better understand this disease? And these are all the centers involved. We have centers in South America, North America, and in Europe that we're very excited to have as part of this big consortium. And this was launched by myself and Paulo Cravetti from Mount Sinai. And we had two amazing physicians, students at the beginning when they started, but now they completed their physicians and their medical training, and they actually continue to work with us, Audrey Uffing and Frank Hulikas. And what the two questions that I would like to finish up, so we allow more time for us to discuss, is, does genetic testing, including APOL1, help predict recurrence? And are there any reliable patients or characteristics that may predict FSGS recurrence, such as in the case that I presented from Jody? And there's a growing number of genetic causes of FSGS. So, the short answer is yes. I think every patient with FSGS should get genetic testing. And there are different ways of getting genetic testing, but I highly recommend to get through your nephrologist. There are panels and whole exome sequencing. The whole exome sequencing can look at the whole genome, and this is the more comprehensive, but there are also some very good panels that test the majority of known mutations. And what we've learned over the years is that there are mutations that have been identified that affect the skeleton of these podocytes. There are mutations that affect the slit diaphragm, so how these podocytes are kind of bound together. There are mutations that we know that affect the mitochondria, which is almost the engine of the energy of the body, of the individual cell. And we know that this can also cause podocyte injury. And also there's some mutations that affect the adhesions of these podocytes when they form the barrier that can also affect this. And why is it important to know about these mutations? Because depending, if you are able to identify some specific podocyte mutations, then your risk of recurrence can go close to 0 after transplant. If you don't have a mutation, then it still raises the question if you're going to have a recurrence or not. And this is part of, studying the circulating factor and trying to identify, what exactly that is. And that brings to the question about, are there patients' characteristics that may predict FSGS recurrence, and there are any potential tests that we can do in the blood to try to define if there's a recurrence or not. I won't go into, too much deep detail about this. But what we are doing with the TANGO study is that we have collected so many samples from very gracious patients that participated in the TANGO study and trying to look at potential circulating factors. And we started with a very unbiased approach. So we're going to be looking at proteins. We're going to be looking at antibodies. We're going to be looking at metabolites without, any preconceived potential prospects of that. I'll share one story that I think is very exciting. This was done, in collaboration with Astrid Weins, who had been studying minimal change disease and native kidney disease, and we wanted to look if potentially the presence of antibody, an autoantibody, could also explain FSGS recurrence post-transplantation. And these are some pictures that she had shared with me, but looking at an antibody against nephrin, and these are patient who has a recurrence of FSGS that clearly had this autoantibody that precipitated the recurrence. And what is this autoantibody binding to? What is it causing in the kidney? So this autoantibody actually binds to nephrin, which is one of the proteins that keep the podocytes membranes kind of together, forming what we call the filtration barrier. So without this, the podocytes cannot keep their structure around the kidney filter. And when this antibody kind of binds to this protein, it seems to disassemble that. And we have now, evidence in the lab where we test these podocytes both in vitro cultures as well as in mice, showing that they are able to destabilize the structure, the architecture of these podocytes, and actually lead to proteinuria, very similar to what we're seeing in our patients. And this is one of our patients that I was taking care of that had a transplant early after transplantation and had a major recurrence. And then when we measure, and the purple here is the degree of proteinuria that you can see that spiked within a few days of transplantation. And what we could detect in this patient is that she had very high levels of anti-nephrin autoantibody. And when we started treating very early with a combination of plasmapheresis that basically filters this antibody, as well as rituximab that shuts off the B cells that produces antibodies, we were able to actually get this antibody level significantly down, and the proteinuria of this patient went down to 0, and patient is in remission now. She's more than a year out, and she's doing fantastic. But really showing that there is a subset of patients that have specifically this autoantibody against nephrin, that now in the lab we're actually able to test for that on a research setting, and hopefully in the clinic we will be able to do this in the upcoming year or two. So in summary, what I showed you here is that genetic testing should be recommended to all our patients suspected with having primary FSGS to help risk stratify risk of recurrence after transplant, and also better identifying what exactly caused them to have the disease in the first place. The second point was that this anti-nephrin autoantibody could be one of the potential circulating factors that explain FSGS recurrence. And why am I saying just a subset? Because we have started to test in a big cohort of our patients, and it's not all patients that have a recurrence that have this autoantibody, and we're still trying to figure out if there are other potential factors that may drive this recurrence. And last of all, of course, we need to validate this in other patients, and this is where the importance about collaboration, the importance about reaching out to our patients and that are interested in potentially giving some blood, letting us kind of test for these antibodies. And this is the TANGO study. You can go to the website, which is www.tangoxstudy.com, or send us an email through contact@tangoxstudy.com, and we'll be happy to kind of facilitate that and help you get enrolled in some of these research studies. We are very fortunate about patients being graceful and kind of sharing samples and allowing us to study, and we hope to in return be able to provide a little bit more information about, what's really causing FSGS recurrence and how could we best treat. And truly, I feel that it's going to be different causes, and we just need to kind of break that apart. And we need a lot of patients to be able to actually identify that. And this is the amazing team that I work, part in the lab, part in the clinic, but I wouldn't be able to show any of the data that I share with you without their help, support, and dedication to our patients and to kidney research. And I'll stop here. I think we're good. We have 20 minutes to maybe go through some of the questions. And thank you, Kristen.
Yeah, absolutely. Thanks so much. There were so many times I was just like mind blown. So thank you. That was really great. We do have some questions, and I have a few of my own, I have to say. But we'll start with some of the ones that were submitted through our Q&A. If you haven't already, go ahead and put your questions in, please. Pam would like to know if you are recommending transplanted patients receive a fourth dose, so the second booster. And I'm curious if there is a caveat in there if they have had like a positive COVID test, if they have actually had the virus.
Yeah.
Does that change the scenario?
Yeah, so we are recommending to have the fourth dose, even if you were infected. And what we've seen, there are actually studies now that have been published showing that, it boosts even further your immune response. And even though we only showed some of the data about the antibody response, when we think about the immune system, we cannot forget about those immune cells that also recognize different parts of the virus. So the antibody, can only recognize what's in the surface of the protein of the virus. So that's why mutations there affect. But the T cells respond differently. They actually respond to, little breaks of that protein that are presented by our own immune cells. So they have a much greater potential spectrum of response that covers, maybe the mutated parts, but also non-mutated parts. They're much harder to study. So that's why you're going to see many more studies just reporting antibody, because antibody is very easy to do. To do the cellular assay to tell if there's a response or not, it's an assay that takes, 72 hours. You have to get the samples fresh. You have to process the immune cells fresh. So it's extremely complicated, and we don't have it available, for us to kind of just run to one of our clinical labs and do it. So you won't see that data out there. But what we can say for sure, based on what we are seeing with some of these breakthroughs and all that, is that there is still protection that comes out of these vaccines. So that's why we're not saying, oh, Omicron, mutated so much, these vaccines are not effective. I'll say no. There is, of course, lower efficacy and lower antibody generation, but we still feel strongly, as well as the CDC, that it gives extra protection. And there is a waning of protection that occurs after vaccination. This is why they're shortening up a little bit the intervals about those, in particular for the transplanted patients.
That's great to know. Another question came in through the chat. Lisa is asking about the use of antivirals for COVID in transplant patients. Can you give us a little bit of discussion around that?
Yeah, so there are mainly two treatments that have been used so far against COVID. So one branch of treatments is what we call the antivirals. So remdesivir and some of the new other drugs, they're basically blocking the virus from replicating. Okay, so there are some drugs, have shown efficacy, such as remdesivir, that have been used in particular for very sick patients. They are starting to use as well for patients that are not that sick, that do not require to be in the hospital, but they require an infusion. So they're not as easy. There's some new pills coming out there. They're antivirals. Some have interactions with the anti-rejection medication. So what you have to do, if any of you are transplanted patients, if you do develop COVID and and you should talk to your transplant team so they can look at, what's available in your institution and look carefully at this drug-drug interaction, because it can lead to toxicity and affect the kidney. So this is the antiviral part, and I think we're learning more and more about, even newer potential pills that could help with that. The second one that I think many of you may have heard are these antibodies. Okay, so instead of blocking the virus from replicating and all that, what the antibody does is just try to neutralize the virus. Okay, so it's kind of doing half of what your immune system usually does whenever it kind of gets a vaccine, which is producing antibody. It doesn't cause your cellular or your immune cells to actually fight any better, but they do help just keep the virus counts lower in the circulation. And now they have been approved also to be used not only for treatment, but also in the prevention. And the way we are using it, just because also it's an injection, we are testing some of our patients that in particular that we believe they have not had a very good vaccine response. So we're doing some antibody testing to see if they have an antibody or not after vaccination. And if they don't have the antibody, then we're giving this medication to kind of protect them. Okay, and why we're not giving to everyone, just at least on our medical center, we have not got the supply to give to everyone. So we're picking the highest risk groups, and there are certain patients, for example, that they get belatacept as one of their immune suppressive drugs, and they tend to respond less to the vaccine in terms of forming antibodies. So these patients, we all are testing for antibody, and if they have antibody negative after getting 4 doses of COVID vaccine, this is when we're giving these monoclonal antibodies that we call. They help them kind of protect their immune system. But the vaccine is still, I think, at the core of all the prevention that we do. And then this the monoclonal antibodies are a little bit extra help that may get. We don't know much information yet how good some of these antibodies are against Omicron. Remember that I showed you that the Omicron had all these purple mutations. And so we still want to see, and that's because the Omicron just happened. So, in the sense that the peak just occurred. So we're still learning how protective they are. But think about the vaccine, the 4 doses as being, kind of the core protection that you're going to need now.
Yeah. Margot had said in the chat that, the Evu Shield, there's limited quantities out there, and it's concerning for her as a kidney transplant recipient. And, she's kind of curious, if you see a time when some of these, antibody treatments might be more available, especially, she's saying, in more rural areas.
Yeah. It's a challenge, and I hear you, Margot. I think, but I always try to encourage our patients to kind of, think about how much benefit they get from the vaccine and how much benefit they would get from the antibody, and the protection that they get from antibody, the extra protection, if you already got the 4 doses of vaccine, it's actually very small. Okay, so I wouldn't be super focused and thinking that if you don't get this monoclonal antibody that you're going to be in trouble. I think if you have gotten your 4 doses, that will give you the greatest chance of getting protected. And then, of course, as things kind of change, as we get more of these, and maybe this monoclonal antibodies will keep evolving, so they're going to get more effective against certain protections and so forth, and maybe be more effective.
That's a great point to make. A couple questions around genetic testing. The first one is from Jen, and she says she's a dialysis patient and she's waiting for her second transplant. She has lost her first one due to recurrence, Fsgs Recurrence. She's curious how you would recommend her go about getting genetic testing. And then along with that, Susie is asking, she has a 9-year-old who has had genetic testing and didn't really show an indicator. That was 4 years ago. And she's curious if there is a reason, or should she, and when should she entertain the idea of getting genetic testing again?
Yeah. So it depends a little bit on what type of genetic testing she did at the beginning. So just to give you an example, so if you go back 5 years, we used to test a few genes. Now we are up to, close to 100 different genes that we're looking at. Yeah. So it has been a huge evolution in that, and it will continue, right? So I think this is just the tip of the iceberg. So there are certain tests that are done. They look for a panel. a panel of genes. They're already known to have potentially cause FSGS. And then you have also the potential of doing what we call whole exome sequencing. The whole exome sequencing, basically you're looking at all the genes you have in your body, like 20,000 genes, and they look, in detail everything that's there. It is something that in the majority of cases is being done on the research setting. So it's not like a clinical test that we're going to send, for every patient who has kidney disease. But if they get enrolled in a study, they could potentially actually get this type of genetic testing done. And there are, of course, some commercial companies now that offer this test that can be done up to, $250, $400 compared to $1,000, $2,000, if you go back 2 years. So the cost kind of keeps coming down, but being in an academic center that has experience in doing genetic testing, they can definitely help you, navigate, because it's complicated even for the nephrologists, general nephrologists, just because the field kind of keeps changing and there's so many different ways for you to order some of these tests. So they have to see what was ordered at your time point, whenever you got the testing, and then see, okay, maybe it was just a few genes and now we are 5 years down the line. It makes sense to repeat some of that testing.
Yeah, absolutely. So Jen's question, she lost her first one to recurrence. She's waiting for her second transplant. And so she's curious about what would you recommend for her to go and get genetic testing? How would that be something she would need to do through her transplant nephrologist? Is this something maybe she needs to look at one of those more commercialized?
I would recommend to go through your nephrologist. Okay. I think that's the best way. And of course, maybe sometimes there are nephrologists in a group that are specialized in genetics. Okay, and this is something that's evolving. I think our group has 2 genetic nephrologists, and so what we do is, if somebody comes for assessment in our transplant program, then we order the genetic testing, we review it. But then we have also these genetic nephrologists that help us interpret some of the information. And I'll tell you, in some cases we won't find an answer. In some cases we find things that are unexpected. And sometimes we find things that, they say it is something abnormal, but we don't know if it actually causes kidney disease. And that's because, the field of genetics, it's something that it's evolving. The more we test, the more we learn. So there is a learning curve along the whole process, but the number of genes that we have now identified that can cause the disease is, it's so high that it makes like no sense in terms of not at least kind of looking at that, in particular in patients who are being considered for transplantation.
Yeah, I'm curious too, for someone like Jen who has had recurrence and she's now going in for her second transplant, the significance around Astrid Wine's research and the nephrin, antibodies, I'm curious if that would also be something that you might recommend, and what would she need to go to her nephrologist and ask for? Yeah. How is that tested? Is it just through a biopsy? You mentioned circulating. Is that something that can be tested in the blood? Yes,
it is something that can be tested in the blood. So we are doing now in the research setting. So we can definitely get blood tested for these antibodies. It is not something that's clinically available already. So just because it takes, these are the steps. And of course, we need to, validating more patients. There's all these kind of curves that needs to go through for a test to go from the research to the clinic. Mm-hmm. So there will be a time lag until we kind of see, a commercial test that you can go to Quest or whatever and kind of order it. So for the anti-nephrin testing, if there are patients that are interested in getting a transplant now and they want to know, the best thing that we can offer in the short term is that they contact us through Tango, and then we can organize the blood to get shipped, and we'll run the assays ourselves. It's run in batches, so it's not as quick as like a 1-day turnaround as you see with your clinical lab. But this is definitely something that we can do. Is it going to change management? So I think this is something that we still don't have enough information. Mm-hmm. But if we compare that to what we know about all other autoimmune diseases that we know there are antibodies, So we would be much more aggressive in terms of trying to remove some of the antibody and giving some treatment to try to control the cells that produce antibody prior to going to transplantation if we knew that these antibodies were present. So this is what we hope to get to. But of course, we're in the early phase of that. But we have a lot of other diseases that affect the kidney, such as membranous nephropathy, that has antibodies that can actually cause also proteinuria, but in a different way. And we know that if we detect these antibodies, they have a higher risk of recurring after transplantation. And I see a question, from one of our nephrologists, Dr. Rubin, who's an old friend. He's asking about the prevalence of some of these anti-nephrin antibodies in membranous and FSGS. And so the membranous have not been detected any of these anti-nephrin antibodies. With FSGS, there is a subset of patients with FSGS that actually have this anti-nephrin antibody. So I see much more the minimal change in FSGS as this spectrum, right, of the same disease, but potential different causes. And depending on how much damage and for how long it happened, it evolves from the minimal change to the scarring phenomenon that we see with the FSGS.
Along those same lines, I'm curious about C3g recurrence. Is there any evidence around the antinephrin with C3g recurrence? Because we know that patient community also has a high recurrence level after transplantation.
Yeah, so the C3 glomerulonephritis, it's also one of these diseases that is on the top of our kind of research list just because they tend to recur more often. Similar to the FSGS, the genetic testing is super important. And there's also functional tests that we can look for autoantibodies. That's clinically available. This can be done. So you look for the nephritic factor, which is an antibody against C3 that kind of explains in part some of these diseases. And we highly recommend undergoing those before transplantation, so you kind of can prepare ahead.
That's great.
But antinephrin and the C3 are both can be antibody mediated, but they cause different damages to the kidney. So in the C3, there are a lot of inflammation that kind of happens. So you kind of trigger all the what we call complement cascade, and there's a lot of damage from inflammation there. While in the FSGS, or if you think about the minimal change, it's much more a damage without actually a lot of inflammation. It's the damage of the cells and the scarring that ended up causing some of the issues down the line.
Yeah. Okay. So I'm going to go one more level here. So let's talk about a C3g transplant patient. We did have a question, in our Q&A that there was her son had a transplant last August. I know that this patient has C3g. Is there, do you as a physician, do you manage as far as medications, the best anti-rejection medicines, are those based on the predominating diagnosis? So she's asking, is Envarsus the best medication he should be on for rejection? So I'm kind of curious, is that also part of your management strategy?
So I'll separate the two things. So one is medications that you're going to use to prevent rejection.
Yep.
And so you usually use 2 or 3 medications, including Envarsus, to prevent the rejection. And then, we think about therapies that would prevent the complement from activating and causing the C3 gene to come back. And why am I separating? Because the drugs that affect the rejection are not the same drugs that are going to block the complement cascade. So, for example, I have patients with C3GN that they're getting an anti-complement treatment, a treatment that basically blocks this complement from getting activated. So it's a monoclonal antibody, and they get these infusions every so often in order to keep their complement from activating. Many of these patients with the C3GN, it's very important to actually biopsy after transplant, even if they have normal kidney function, even if they don't have a lot of protein in the urine, because you want to be able to detect any potential damage even before it starts. And independent if you had genetic testing or other functional tests, I think that's important, in the pre-transplant world. Once they get transplanted, we want to monitor these patients very carefully. And of course, we do blood tests, we do urine tests. But one of the things that it's also relevant is, to looking at the kidney to ensure by the end of, say, 6 to 12 months after transplant, that they prove, or at least look themselves, indicating biopsy to ensure that there's no significant recurrence. If there is, there's always the option of kind of treating that and starting early before there's actually creatinine going up and other complications that we see that may happen after transplantation.
That's great. I know that we are going to have to close up. I know that there's still quite a few questions. I will tell you that I will go through those questions and send some to Dr. Riella, and maybe you can answer some on your off time. And I can definitely get these back to the community who asked them. One comment from Pam, she said this was one of the best lectures she's ever attended. She's really thankful for the clarity of explaining everything in a way that the lay community can really digest and understand. Her daughter was diagnosed with FSGS and transplanted, and she's just very grateful and encouraged by what you have shared today. So, and I think that really speaks to all of us here. And we really thank you so much for being here. This really has been an amazing, amazing educational webinar, one for the books for sure.
Thank you. Thank you so much. And I'm glad to come back anytime.
Thank you so much. Have a wonderful day. And if you are interested in the Tango study, is there a website that they can go to, Dr. Riella?
Yes. Yeah. So it's at tangoxstudy.com.
Great. And I will provide that information about the website and the Tango study in a follow-up email by the end of tomorrow. So thank you so much, everyone, for being here. Have a wonderful day. Thanks, Dr. Riella.
Thank you. Have a good one. Bye-bye.